This video is the first in a series aimed at senior medical students and interns on how to handle common cross-cover calls. The topic today is altered mental status. The learning objectives of this video are to know the diverse etiologies of altered mental status, be able to identify presenting features that suggest a patient is gravely ill and requires a higher level of care, understand the clinical types of altered mental status, know the initial workup of altered mental status, including which patients require a head CT, and finally, to understand and be able to employ basic treatment strategies, including both non-pharmacologic and pharmacologic therapies. It's 1 o'clock in the morning, you're the overnight medical resident in the hospital, and you're just getting ready to finally get a few minutes of sleep. Suddenly, that dreaded sound. You reach over to your nightstand and pick up your pager. It's Ward 2A. Patient J. Smith, on whom you are cross-covering, is apparently agitated and confused, and the nurse is suggesting an order for PRN Haldol in addition to urgent bedside evaluation. Before even discussing causes and appropriate evaluation, realize that altered mental status is one of the most dangerous cross-cover problems because of the extreme variation in seriousness among common etiologies, as well as the relative ease with which life-threatening problems can be perceived as benign. As you hurry over to the medical ward, you should think through the etiologies, focusing on those that are common and or unusually dangerous. When you arrive at the bedside, you should first be concerned with assessing the severity of the patient's condition. Concurrent with assessment of severity should be an initial evaluation to identify the cause, and finally, you should order initial treatment if it's indicated, which, if the patient truly has altered mental status, is probably the case. As I mentioned a moment ago, the etiologies of altered mental status are quite numerous and varied. Let's limit ourselves to causes that can occur in the hospital. And even if we further limit ourselves to etiologies that are either common or dangerous, there are still a large number left. Instead of just listing them randomly, let's consider a framework into which they could be categorized. Altered mental status can be from hemodynamic derangement, which is nearly synonymous with shock, but also includes things like hypertensive encephalopathy. It can be from a derangement of gas exchange, predominantly hypoxemia or hypercapnia, but also includes methemoglobinemia. Acute CNS lesions include both intracranial hemorrhage and ischemic stroke. Medications are a major cause of altered mentation in the hospital. All healthcare providers are familiar with opiates and benzodiazepines as major causes, but here are a number of others. In addition to conventional medication side effects, there are two additional medication-related complications to remember. First is serotonin syndrome, which is typically caused by a medication interaction between some combination of antidepressants, triptans, ondansetron, and a variety of illicit drugs such as cocaine, amphetamines, and ecstasy. Second is the neuroleptic malignant syndrome caused by antipsychotic medications. Various types of drug withdrawal syndromes can happen within the first several days of a patient's hospitalization. Alcohol and benzo withdrawal are typically the most dangerous. Opiate withdrawal can also be very uncomfortable, but is rarely dangerous. And cocaine and amphetamine withdrawal is typically more mild in its manifestations. There are many metabolic derangements that can acutely develop in the hospital, particularly those of glucose, as well as sodium and calcium. Although confusion from uremia and hyperammonemia typically doesn't develop abruptly, it can develop over the course of 1 to 2 days. And the severely deranged pH can also lead to altered mentation. Finally, there are also some miscellaneous causes to consider. Sundowning is one of the most common causes of abrupt confusion and agitation in the hospital. This term refers to the phenomenon in which patients with dementia tend to become more confused and agitated at night than during the day. There is hospital-acquired delirium due to the combination of acute illness, an unfamiliar environment, disrupted circadian rhythm, inadequate pain control, and polypharmacy. Infection in the systemic inflammatory response syndrome can lead to confusion, even in the absence of hemodynamic problems. Surprising to many people, acute urinary retention in the elderly can also cause confusion and agitation. And rounding out the list of considerations are surreptitious drug use while in the hospital, manifestation of pre-existing psychiatric disease, and the seizures. When you arrive at the bedside, as you begin your evaluation, one of the first things to do is to assess the severity of the patient's condition. Within only a few minutes, you should already have an idea as to whether you need to call for additional help and whether the patient needs to be moved to a higher level of care. When making this determination, although the specific diagnosis may not yet have been established, consideration of the etiologies will still be helpful. While there are relatively few conditions on this long list that could be called benign, when you look it over, are there any of these that seem even more dangerous than the others? In general, the rightmost column seems to be more dangerous. That's because the diagnoses listed here acutely impair oxygen delivery and/or utilization in the brain. The only other condition on the screen that's in the same range of seriousness is hypoglycemia. You probably know that irreversible neuronal damage can occur within minutes of impaired cellular respiration in the CNS. And in fact, these are the conditions that can kill a patient within minutes. So if any of these are thought of as likely diagnoses, strongly consider immediately getting more help or moving the patient to an ICU or step-down unit. The only major exception to this is hypoglycemia, which can often be reversed quickly by simple administration of glucose. Here's a more practical checklist. Strongly consider calling for more help or transferring the patient to a higher level of care if hemodynamic instability is present, you are considering a diagnosis of cardiogenic shock in which hemodynamic instability may not necessarily be overt, hypoxemia is present, which is either unexplained and/or requires treatment that exceeds what the current nursing unit can provide, hypercapnia is present that is severe enough to require non-invasive positive pressure ventilation or BiPAP, you suspect methemoglobinemia, new focal neurologic findings are present, or the patient is either unarousable and/or is not adequately protecting his or her airway. What should a focused and time-efficient initial evaluation look like? Let's divide tasks into those best handled by you as a cross-covering intern or resident, and those best handled by the patient's nurse, a medical student, or other assisting house staff. You should generally recheck vitals yourself to eliminate any uncertainty as to whether vitals provided by ward staff are current. Next, consider the details of the sign-out you received on the patient from the primary team. For example, maybe it will mention that the patient has had similar episodes that have been successfully treated with such and such, or maybe it will mention a new medication that was started today. Using any history provided by nursing and the sign-out to guide you, you should then perform a focused physical exam, which should include, but not necessarily be limited to, a typical cardiovascular exam, and something one could call the 5-minute neuro screen. This is essentially a very quick neuro exam designed to look for life-threatening problems in a confused, potentially non-cooperative patient. This neuro screen should include assessment of the level of consciousness, assessment of speech and language, assessment of attention, which is usually done by checking the patient's ability to follow directions, which itself requires that language centers are intact, orientation, cranial nerves, frequently omitting more time-consuming and lower yield portions such as visual fields and visual acuity, gross strength in all 4 extremities. Each individual muscle group does not need to be independently tested for this quick screen. In addition, in unconscious patients, look at the respiratory pattern, which can demonstrate specific abnormalities in certain neurologic conditions. And finally, in a patient who is not spontaneously moving his or her extremities because of unconsciousness, test that they withdraw each of their 4 extremities in response to a painful stimulus, such as pinprick or applied nail bed pressure. Tasks for the others present in the room include checking blood glucose, which should be one of the very first things done, review the medication list, focusing on those meds given over the past several hours, including PRNs. If the altered mental status is really a mystery, consider checking the med administration record for the patient's roommate, as a medication administration error could be to blame. Review labs from the previous 24 hours, particularly electrolytes. Review substance abuse history and check admission urine tox screen, if one was done. Check a basic metabolic panel, including calcium, either an arterial or venous blood gas, a urine tox screen if there's any chance of surreptitious drug use, and a UA and urine culture if there's a risk of UTI-triggered delirium. Finally, for patients at risk of acute urinary retention, consider checking a bladder scan, which is a pseudo-quantitative assessment of current bladder volume made via a simple ultrasound device. As you perform this initial evaluation, after determining the overall apparent severity of the patient's condition, the next most important immediate consideration is determination of the clinical type of altered mental status which the patient is exhibiting. For example, is the patient delirious? Where I'm using that term in a medically precise fashion to mean an acute disturbance in consciousness and cognition that fluctuates throughout the day. If yes, you should decide if the patient is experiencing a hyperactive delirium, in which the patient's agitation predominates, a hypoactive delirium, in which the patient's somnolence predominates, or a mixed delirium, with roughly similar contributions of agitation alternating with somnolence. Although we typically imagine the hyperactive agitated patient when we think of delirium, hyperactive delirium is the least common of the three varieties. Now, if a patient is not delirious, that is, if either the level of consciousness or cognition is not impaired, or if the clinical course does not seem to fluctuate, you are dealing with non-delirious agitation or non-delirious somnolence. A somewhat unique form of altered mental status is catatonia, in which the patient's level of consciousness is more or less normal, but he or she interacts minimally with the outside world, exhibiting mutism, severe psychomotor slowing, and lack of volitional activity. Catatonia can have either psychiatric or neurologic causes. So this gives us 6 general clinical types of altered mental status, which will help our differential diagnosis. One of the most helpful distinctions is whether the patient is predominantly agitated or somnolent. Let's return to our very thorough list of common or dangerous etiologies of altered mentation occurring in the hospital. Here's that list, limited to those etiologies that are commonly associated with agitation. Particularly important here is early shock, hypoxemia, alcohol and benzo withdrawal, and hypoglycemia. Now here is the list limited to those etiologies that are commonly associated with somnolence. The particularly important conditions here are hypercapnia, medication side effect, and hospital-acquired delirium. You may have noticed that some diagnoses show up on both lists. Unfortunately, that's because some conditions can just as easily cause one as the other, which slightly limits the distinction's ability to suggest the diagnosis, but it's still relatively helpful at the bedside. During the initial evaluation, a common question to come up is, should this patient get a head CT? This is not needed for most patients. Of course, every case is different, so the following should be taken as a general rule of thumb and not dogma. Situations where evaluation of altered mental status requires an urgent head CT include a new focal neural finding which persists despite reversal of any quickly reversible physiologic derangement. For example, some patients with hypoglycemia or hypoxemia can develop focal neural findings which completely resolve once the patient is given glucose or oxygen. This may represent sequelae of remote subclinical stroke or other clinically silent prior neurologic injury, a history of recent head trauma, or a diminished level of consciousness when no obvious cause is found on initial evaluation. I'll conclude by briefly discussing some acute treatment options. Altered mental status is always best treated by correcting the underlying problem. Consider the patient's fall risk. The last thing an elderly agitated patient needs is a broken hip. Consider discontinuing any unnecessary lines and tubes which could pose risk to an agitated patient. Consider whether the patient should have a sitter, that is, a hospital employee whose job is literally to sit next to the patient to ensure that he or she does not hurt themselves. And remember that physical restraints worsen agitation and should only be used if critical for patient safety and if there are no alternatives. If we return to the initial page that started our discussion, it's common to consider pharmacologic therapy to control altered mental status, particularly agitation. In which patients is this appropriate? This may seem obvious, but antipsychotics may be indicated when a patient's agitation is severe enough that its risk to the patient outweighs the risk for the medication. The major risk of antipsychotics is QT prolongation and sudden cardiac death. Atypical antipsychotics, such as quetiapine and olanzapine, are generally not felt to be superior to low-dose haloperidol for most patients in this situation. An appropriate dose for control of agitation in a medically ill patient, at least to start off with, is 0.5 to 1 milligrams of haloperidol, PO or IM. It can also be given IV, but with mildly increased concern for arrhythmias. Particular caution should be used with antipsychotics in the elderly. Despite the aforementioned treatment being relatively common, at least common in the United States, be aware that the literature evidence supporting the use of antipsychotics to treat acute confusional states in medically ill patients is limited and has had mixed results. Finally, what about benzodiazepines? Because they are sedating, occasionally they are suggested or requested to control behavior in an agitated, delirious patient. Unfortunately, benzodiazepines carry a significant risk of worsening delirium. They should only be used in cases of alcohol or benzo withdrawal, suspected catatonia, in which benzos are the primary pharmacologic treatment, and in the severely agitated patient who has a strong contraindication to antipsychotics, such as a pre-existing QT prolongation. I hope you found this brief review on handling altered mental status while on crosscover helpful. If so, you may want to check out some of my other videos on common crosscover problems.